Self-monitoring of blood glucose, alternatively called home blood glucose monitoring, is a very controversial area, and it's controversial largely due to cost. So there was a survey in the UK that was published, I think about 6 or 7 years ago, which at the time suggested that the NHS was spending more on blood glucose monitoring strips than for the entire oral therapy spectrum of treatment. So clearly it's seen as a big expenditure, and not unreasonably, if it achieves very little, then it's a reasonable focus for cutting down on costs. Now, the literature is not particularly helpful in terms of advocating home blood glucose monitoring, because it's been very difficult to demonstrate that adding that level of information and activity to patients' lifestyle and diet management makes any difference. So most of the studies suggest that patients testing their own blood glucose has very little impact on HbA1c outcomes. And indeed, some studies have suggested that regular testing of blood glucose causes anxiety and depression and symptoms that are actually deleterious to the patient with type 2 diabetes. However, on the other side of the equation, we have issues of patient empowerment, and we also have the situation where diabetes is a condition where patient education is absolutely crucial, and we would like patients to be able to assess the impact of different aspects of their diet on blood glucose levels, and also to manipulate their therapies. And this especially applies to patients treated with insulin, but equally you could argue that up-titration of medications is done very slowly in the UK, and that if patients were able to take this on their own at home, then they might achieve either the highest dose that's appropriate or the highest tolerated dose much more quickly than is currently the case, with that being guided by medics. I think the bottom line is that unless there is definitely an advantageous outcome to blood glucose monitoring, then it's probably something that can be avoided or only introduced into therapy later on. So in a patient who is on diet treatment only that you don't expect to be able to correlate blood glucose levels with the aspects of their diet, then I think there's very little place for home blood glucose monitoring. And similarly, in those patients who are on therapies that don't induce hypoglycemia, then I think blood glucose monitoring can often be omitted in those cases, because essentially the practitioner is going to be manipulating therapy based on HbA1c targets rather than on the patient's self-monitoring levels. I think self-monitoring definitely has a place where hypoglycemia is an issue, and so that might well include patients given sulfonylureas, and it would definitely include patients who have been treated with insulin. And here it is essentially a hypoglycemic detection tool, because hypoglycemia, when we go looking for it, and we look for it much more frequently now, for example with continuous blood glucose monitoring, which can be used as an assessment tool before intensification of insulin regimes. Well, if you look for hypoglycemia, then you'll find it much more frequently than you expect. So I think blood glucose monitoring certainly has a potential there. Some people advocate use of urine testing. I think there's very little place for urine testing in the management of type 2 diabetes in our modern era. I think for some it's almost used as a punishment because it's not an overly pleasant thing to do, and there are issues partly around glycemic threshold, although I think this has perhaps been overplayed, but more the fact that you're looking at a accumulation of glucose over a long period, so it's very difficult to manipulate therapies, and of course there's no way of detecting hypoglycemia by using urinary glucose monitoring.